So these were the few questions. Now, guys, before I go into infectious diseases, I need your help. You see, no one is perfect, and I'm definitely not perfect. I'm learning, and you are teaching me, and I'm learning. Please give me feedback that what questions I need to put in and what I must take out. I have been doing this course voluntarily to my Leicester University UK students, and obviously they have been teaching me and guiding me. And I'm continuously improving and finishing this course almost on daily basis. That is my obsession, you can say. But I know that there is always a room to improve, so I will need your help to make it further better.
Sir, with your permission, sir, I think in this given time you have done excellent job, and it cannot be better than that. You have covered every aspect almost.
Thank you. So continue to guide me, continue to help me so that I can help younger budding colleagues so that they can have a quick revision in a short course of time. Right, okay, now, and you know, I am getting some unhappy text messages because some 600 people have not been able to get into this course. You people have been lucky. To get in. So many people have not been able to get in. So we will try to find a solution for those colleagues who have not been able to get in. Right, okay. Infectious diseases, it's a wide kind of pathologies, wide variety of pathologies you can get in infectious diseases. I have put in those common topics which keep appearing in the exam every now and then. They appear on repeating basis. Okay, first question. Guys, a 16-year-old girl, always look at the age. Certain diseases occur at a certain age. For example, this diagnosis here does not occur in 60s, 70s, 50s. So you have to be very careful that the information we give you in the question means something. Abira thinks that this is A. Is it? How many people agree with Abira? Right. 16-year-old girl has an enlarged mass on the right side of her neck. What is that? That could be a lymph node. She has a 2 by 2 centimeter lymph nodes in the right anterior triangle of the neck and several smaller cervical lymph nodes. Her tonsils are enlarged and covered by a gray membrane. What is the diagnosis? So that is your infectious mononucleosis. Sorry, this has been twice. So that is your lymph nodes, and that is how the throat can look like, right? Can someone tell me what diagnostic test you do to confirm the diagnosis? Basically, most GPs will be happy to make a clinical diagnosis. It is due to EBV virus, correct? And Nawal, you think this will be monospot test? How many people will disagree with Nawal and how many people will agree? We don't do Paul Burnell test. We do this monospot test, and we can have a look. We can see atypical lymphocytes as well. Correct. So EBV virus monospot test, usually diagnosis is clinical. When GP sees this patient, my suggestion would be that they recall this patient and make sure that that these changes have resolved. Okay, moving on. Right. Okay. Now, this question is very topical. I would want all of you to be very alert. I have given a very realistic clinical scenario, which I have seen it quite often. I have been managing COVID patients in the last few months, and this time we have a 47-year-old male presenting with a history of shortness of breath, fever, and dry cough and body aches. On examination, he looks unwell. Temperature is high, 38 point high, saturation 91% room air, and has bilateral crackles in the lower zone. His CRP is 189, WBC 11 with low normal lymphocytes. His PCR for COVID-19 is negative. This is slightly tricky question, and I deliberately put this trick in. Before you commit yourself, please read this question again. Have a look on the chest x-ray again, right? I want you to give me an answer which incorporates all the information I have given you. PCR for COVID-19 is negative. Remember, up to 30% of the patients in COVID, they can be negative for their PCR. Community-acquired pneumonia is usually unilateral, but not bilateral, right? It cannot be flu, right? X-ray is abnormal. I'm showing bilateral lower zone consolidations. The picture is typical for COVID, right? A typical triad, shortness of breath, fever, dry cough, and body aches. Temperature, usually CRP is up in bacterial, but COVID-19 has shown that CRP is usually high when respiratory system is involved. I am glad that people are starting to say it is COVID-19 pneumonitis. Yes, it is COVID-19 pneumonitis. In spite, I had so many patients where PCR was negative, but the picture was so typical and chest X-ray was helpful. This is not one of the best X-ray I've shown. There are better X-rays showing bilateral lower zone consolidations, right? A typical clinical picture, right? Needing oxygen, hypoxemia, high-grade temperature. So yes, differential diagnosis is very tight with community-acquired pneumonia, but in the given clinical scenario, right, with normal white cell count where it is possible in pneumonia, but this is unusual. So that is why, and then you have got almost, we are limping towards lymphocytes, right? So lymphopenia is impending. So I slightly made it difficult. Lymphopenia is a feature. High CRP is a feature. Bilateral lower lobe pneumonitis is a feature, right? So this is not COPD. Nothing information has been given towards COPD. It is not enteric fever. Enteric fever is not giving you bilateral consolidations, right? Okay. I'm glad that many of you were able to pick up. I made it difficult. I worked hard to make this question because I just wanted to keep a mix of easy and difficult questions. This is slightly above average question, but then I just wanted to keep you awake and alert that PCR negative for COVID. You have to be very careful to interpret these results. Your clinical judgment is more important. Okay, now this is another clever question, right? I want a correct answer again, please. What is the first line treatment that you should be given? So the thing is that there are several questions in this one question. You can answer this question only if you know what exactly is going on. That why Sadia Rashid, C. The answer here is intravenous fluids. People have got it right. This is C actually. This atrial fibrillation. So ECG shows irregular R2R intervals. That is your atrial fibrillation. Atrial fibrillation, this patient is not known to have any rhythm abnormalities before. So you see, she has no history of AF, atrial fibrillation, but now she has AF. That is due to sepsis, right? So you will treat with IV fluids. So that is the first answer. Correct. Okay. Moving on.